Good afternoon, everyone. Thank you for joining us for this special edition of our webinar series. This is actually our sixth annual Fireside Chat. We do it around Christmas time every year, and so we're excited this year because we actually have a new executive director. And so I'm going to let Jo Beth, our new leader, tell us a little bit about herself briefly and say a welcome to everyone, and then we'll continue on with our fireside chat for this year.
Thank you so much, Dr. Snyder or Shonna. Hello, everyone. I'm Dr. Jo Beth McCarthy. You could call me Jo. I'm the new executive director of the Pheo Para Alliance. It's an honor to be here with you. Our mission is rooted in one simple belief that every person facing Pheo or Para deserves clarity, community, and hope. And I'm grateful to work alongside our incredible families, patients, and clinicians and researchers who dedicate their lives to improving diagnoses, care, and outcomes. And thank you for being part of this journey with us. Thank you.
Thanks, Jo. We appreciate it. We're so glad and happy to have you on board. Looking forward to doing many, many things in the upcoming years with you as part of our leadership team. So as most of you know, so my name is Dr. Shonna Snyder, and I am a paraganglioma patient of Dr. Patsak's when he was at the NIH. So I had a bladder paraganglioma. I'm not going to go into a lot of detail on my story because I feel that you can hear it on some of the other webinars. So, but just know that I have been where some of you are. I understand the journey. I also sit on our board, and so I have a very good connection with the patient side, but I understand the organization side. And so we're very excited to bring this year's fireside chat with you. So I am here with Dr. Pacak, and I'm going to formally introduce him here in just a second. But let me do some housekeeping things first. So this program is brought to you by the Pheo Para Alliance, whose mission is to empower patients with pheochromocytoma and paraganglioma, their families and medical professionals through advocacy, education, and a global community of support, while helping to advance research that accelerates treatments and cures. So special thanks to our community for making this webinar series possible through your donations and your support. We would love for you to stay in touch with our Pheo Para news by signing up to receive emails at pheopara.org and follow us on social media. If you do the @ Pheo Para, you'll hear, lots of things will generate, and you can follow all of those hashtags. So our agenda today is entirely a Q&A, question and answer format, and we have questions that have been submitted from many of you in the community, and so we will do our best to answer as many of those as we can. The questions that are similar in nature, we may combine those, so if you don't hear your exact question, listen, because it may still be a similar question that's very similar to what you submitted. So do pay attention to kind of the type of question that it is, and we very well may answer your exact question, okay? Some of the questions we may not get to, but we will do our best to get to all of them. If your question was very case specific, we will probably hold that off to the very end to see if we have time. And we always recommend that you do reach out to your clinicians and your medical professionals in your life and try to get your specific questions answered. Our disclaimer for today is that the information presented on this webinar is for educational purposes only and should not be substituted for the advice of your doctors and medical team, because they have that in-depth knowledge of your medical history and current situation. Okay, so having said that, I'm going to introduce you quickly to Dr. Pacak. Again, I don't think he needs a big introduction because most people know him, and we've introduced him many times on this fireside chat. But Dr. Pacak is now working and practicing over in Prague. He was formerly with the NIH, and that's how most of our patients know him. And I will say that as as a patient of his, I can't thank him enough. I try to thank him every year for how he helped me. And I know he's helped many, many other patients. And he is just a great person to answer these patient questions that we're going to get through today. And so one of my first questions that I'm going to ask Dr. Pacak today is, how are you doing and how is Prague? I think a lot of our patient community wants to know, like, how things are going over there.
First of all, thank you so much, Shonna, for the very nice introduction, very nice words. And I would like also to welcome Joe Bess, as our executive director, because as you know, I had the medical advisory board for Pheo Para Alliance. It's really great pleasure and honor to be here actually today. I think it's for the sixth time. What I also like that Shonna, even, the American person, she actually very well pronounce my name because, pronouncing my name, my last name is a little bit more complicated than you think, so she's doing very well. So the question was how I'm doing in Prague. So for everybody, I'm in Prague not because, I was asked, at the NIH to leave NIH. The opposite is true. Actually, there were a lot of good things, before I was leaving and maybe some offers. However, because of the family reasons, I moved to Prague. But I have to tell you honestly, I'm still working very heavily on the pheochromocytoma paraganglioma, working in the basic as well as clinical research as a very close ties, with the NIH and with many groups in the United States as well as internationally. For example, we will be preparing, new guidelines related to pheochromocytoma paraganglioma, and many interesting studies actually coming out. So I definitely, for patients, I did not abandon you. And of course, if you would like to contact me, you are very, very welcome. Some of you are contacting me, and it's very good. The life in Prague is, of course, different, and I will always miss US because, I'm US citizen, but also Czech citizen. But, my productive years, the most productive years I spent in US, I feel that, I'm more American than Czech. But, as I said, this is how it is. And sometimes, you have choice and sometimes you don't have choice. So I hope that you understand, but I'm always with you. And in case that you need something, I will be more than happy actually to advise or to help you or even to welcome you to our clinic here in Prague, where I had the Center for Adrenal Endocrine Tumors, including pheochromocytoma and paraganglioma. I will not say more because I'm pretty sure you want me to answer your questions, and I will be happy, to do my best, to answer your questions and to be with you, and hopefully, things will go well. So once again, thank you so much for your Para Alliance, as well as others, for, very, very kind invitation. And it's really honored to be here, today and to be with all of you. Thank you.
All right. With having all that said, I think the patients can still feel very confident that you are in our corner and you're still working for us. I think some of them were a little worried. So that gives a lot of patients some reassurance. So that's awesome to hear. And I think that kind of leads us into some of our first questions today. Is, as most of our patient community knows, that we had Belzutifan kind of come on the scene this year. And so there have been a lot of questions from our patient community about what is Belzutifan? How does it work? Is it right for me? What are maybe potential side effects? What is the efficacy? How good is it? In other words, is it actually going to help me? So I think I would like for us to just kind of have a little chat about Belzutifan first, if that's okay.
Yeah, absolutely. And, so the Belzutifan is new drug that was actually approved by FDA on May 14. if I remember well, 2025, this year. And the really paramount study was published on November 4th in 2025 as not only national but international study. The belzutifan is interesting drug, because it's affecting hypoxia-inducible factor, the stabilization of this actually transcription factor, because this transcription factor is involved in actually regulation of many genes, and those genes are related to actually tumorogenesis of various tumors, including pheochromocytoma / paraganglioma. So the belzutifan affecting hypoxia-inducible factor, we sometimes abbreviate it in HIF, and actually I would say the resulting in the good response in some cancers in terms of whether it's primary or the metastatic tumor. The first time it was especially used, for example, for VHR-related kidney cancer, then hemangioblastomas, and right now we have pheochromocytoma and paraganglioma. You ask me, what is the effect actually of the belzutifan? So the disease control rate is approximately 85%. So the reduction, which means, that there is some response of the tumors, and it depends on the genetic background. It's about 26% of the patients or so. And the stabilization, it's approximately 59%. So if you put everything together about the disease control rate, it's approximately 85% of patients, which is, a very good number, so only 15% of patients most likely will not respond, to belzutifan. So definitely, very good achievement in terms of using this drug practically on daily basis, and having actually good response. And one of the, only the drug just now that is approved by FDA for metastatic pheochromocytoma paraganglioma. We had before another one, which is high specific activity MIBG, but unfortunately in 2024, I think in April, if I'm not mistaken, was discontinued. So this community Pheo Para Alliance community or patients actually were left only, with belzutifan. But, if I compare, with other, the medication, especially, for example, radiotherapy, which is which is using lutetium-177 dotatate called Lutathera, the responses are pretty much the same. It's approximately 85–86%. Of course, it's a little bit different therapy because here we are talking about, the belzutifan as a pills. In terms of Lutathera, we are talking about the radiotherapy. But everything has, pros and cons. But I just wanted to tell patients that if even they cannot get the belzutifan because it's very expensive drug, may and may not sometimes be approved, whatever the reason is, even, it's approved by FDA, then has to be taken on daily basis. If you have, for example, radiotherapy, you have certain cycles for the radiotherapy, then you are done. And, you can have stabilization of disease over, several years or even, over, the many years. So it depends, what is going on with the patient, where the patient stands, what kind of tumor or tumors the patient has, what is the extension of the metastatic disease. The belzutifan is rather or possibly will be more effective in those that are related to so-called hypoxia signaling pathway. So that means, those tumors that belong to, for example, the mutation are related to Krebs cycle or hypoxia signaling pathway, maybe less to those who are related to multiple endocrine neoplasia, neurofibromatosis. Although, the data from the article that was published in excellent journal, New England Journal of Medicine, are not absolutely just now clear, what's going to happen, with those patients where hypoxia signaling pathway is not the most important one. But I am pretty sure that many scientists and many those who were involved in this clinical trial, that is definitely very good, and we are very happy to have this clinical trial, are working on that, and then we'll be extending the group of the patients and seeing, some results in the near future.
Yeah. So one question that comes to mind is, would this be something, could there potentially be a patient that might take Belzutifan and Lutathera, for example? Would that be a scenario?
Yeah, so it's definitely, the possibility, because, we will talk about, some synergy, and there are already actually, I would say, not only some studies in preparation, there may be something ongoing. For example, combining this drug with, for example, tyrosine kinase inhibitors, or the combining, with PRRT peptide receptor radiotherapy, which represent, for example, the Lutathera, but it may be, of course, something that could be combined with so-called alpha therapy, which I think that would be very interesting and possibly game changer, in the future for some patient with metastatic disease. Yes, definitely. This will be good approach. This approach is already in the discussion. I'm not involved exactly in, I would say, not only preparation, but outline design, what is going to happen, with Belzutifan these days. But I know that, some groups and some experts are already thinking about actually this combination, and to see, what may happen and how actually the patient can respond, to those combinations.
That's great. And that was one of the questions that we did receive, is what are some things coming down the pipeline? And it sounds like this may be some of the new things that are coming down the pipeline, to see if these combinations work together well, and what's the outcome if we do some combinations of things. So
yeah, I think that they
that's
will. Some of these combinations may work well. I can actually imagine that, for example, radiotherapy PRRT, is combination with Belzutifan, maybe something of the interest. The only, the problem may be, so because it's radiotherapy, systemic radiotherapy affecting bone marrow, and of course the bone marrow, will be suppressed. And Belzutifan, the most problematic, the side effects, so it's anemia, because, that's can be really problem, because HIV is, very good regulator of erythropoietin. And if you don't have a HIV, you will not regulate erythropoietin or expression. That means, the EPO, that is very much involved in the generation of red blood cells, so causing anemia. And the combined effect of anemia from the Belzutifan, which can be sometimes severe, it depends on the doses, and the systemic radiotherapy, maybe, of course, some limiting factor. Of course, we can decrease the doses, like, not only for radiotherapy, but, doses for Belzutifan, because the dose is usually 120 milligram per day, but you can go even lower, up to 80 or 40 milligram per day. It will really depend how, some individual patients, will actually react to this medication, and even, the combination, and then adjusting, the doses of each, I would say, treatment modality.
excellent. So one of the questions that just came in as we're talking about this, and we're saying that it's for those who are metastatic, the question was, how are we defining metastatic?
Oh, so this is the new definition based on WHO. WHO is the World Health Organization from 2017, and then revised or modified in 2022. Metastatic disease is the disease where the chromaffin cell, and I would say here, for patients to a little bit to simplify, the tumor cell will be actually present in tissue where those chromaffin cell, because these tumor cell are actually derived from chromaffin cell, are not normally present. And there are only two tissues, believe it or not, and this is in bones and lymph nodes. So once you have something in lymph nodes or bones, it's definitely metastatic disease. There is exception. There are, maybe 2 or 3 papers published that primary tumor can actually arise from the bone. But, for the patients, practically, forget it, okay? So,
Right.
but then you have, the lesions in the liver, spleen, pancreas, lungs, and I'm pretty sure 99% of patients who are listening to this or watching this webinar would say, "Oh my God, he's not correct." Yes, I am correct, but I am not correct. Because it depends on the clinical scenario. If somebody has 3, 4, 5 lesions in the liver, of course, we know that those lesions will be metastatic lesions. And we will not talk about the primary tumors. The primary tumors in the liver, for example, in lungs, and I had several patients with these primary tumors are usually solitary tumors, okay? And it's even difficult sometimes, to distinguish between, the primary metastatic, although there are some interesting pathologic markers where we can presume or predict, whether it's primary or metastatic. So it really depends on the clinical scenario, okay? But as somebody asked the question, the answer is only lymph nodes and the bones.
Okay. All right. That's very good. So if we are thinking about Belzutifan, what if you are not metastatic? Could you
Ah,
use Belzutifan still?
yeah, so well, the data is actually missing or not available except for one group. So if I would have solitary tumor, pheochromocytoma, paraganglioma, not knowing anything about the genetic background and will be advanced, which means locally, for example, growing, into, some surrounding structures, maybe causing some problems, including, for example, pain and other symptoms and signs. Possibly we could use the Belzutifan if, for example, radiotherapy will not be the option because, it depends on the location of the tumor. Then the Belzutifan would be definitely interesting option. Whether the patient will respond to Belzutifan, I cannot say. I am not absolutely
Right.
sure if it would be SDH, succinate dehydrogenase, A, B, C, D subunits. Possibly it would be VHL related primary tumor. Possibly that would be good, and I would say that most likely they will respond to certain extent. However, if we don't know anything about genetic background, we cannot predict what the response will be. However, if you take, those that they have a HIF2 alpha mutation, okay, or EPAS1 mutation, those are the patients who actually present also with, for example, polycythemia. Sometimes they have other neuroendocrine tumors, especially, sitting in the duodenum called somatostatinoma. It's mainly in females. I would say that in 99% of those patients are females, that I guarantee you that if you use the Belzutifan, those tumors will respond and they will respond extremely well and they will respond very quickly. So in 3 weeks, 4 weeks, you will see very good response. And maybe, over 2 or 3 months, the response can be sometimes between 40 to 70%, which is very important. Again, if you will have it, in the location that is very difficult to be accessed by surgeons or, using, for example, some specific therapy. And I'm not talking about systemic, radiotherapy, but for example, external beam radiation for whatever the reason will be, then, the belzutifan will be good. The drawback is, that to have a HIV mutation or EPAS1 mutation, this is very small group of patients. We had approximately, I would say, 20, 25 patients at the NIH at the time when I was there. And worldwide, I don't know how many patients are actually there, so, but it definitely will be this one of the smallest group of those who have, some genetic background that is related to the development of pheochromocytoma paraganglioma. But the belzutifan there will be the most successful and will work extremely well for these patients, not only for the tumors, but will also be very good in terms of reducing the erythropoietin. So polycythemia will practically disappear. And also it has very good effect for elevated catecholamines. So the patients will, if they will not stop antihypertensive medication, the antihypertensive medication will be reduced by 80-90%.
I think that is really good news for patients who are listening now who may be considering themselves as not metastatic, but they have a tumor that can't be resected by surgery and some of the other things that you just said. I think that's really good news. So
Yeah, but
that's fantastic.
they will most likely need, some approval from insurance company, but I think
Sure.
that they may succeed, especially in the United States. We usually, succeeded, with some patients because the insurance companies they are approaching, this kind of request very carefully, and usually they put together a very good detailed review and insight, and some of them are very knowledgeable and helping patients.
Excellent. So one of the things that you mentioned as we were talking, and it is a question that came up, you may not know the answer to this, and it's okay if you don't, because we know that you have left the NIH, but we did have a couple of questions asking what you know about the research that is still going on at the NIH. And I know there's been some budgeting issues and some different things, but in general, are you aware of what is still happening at the NIH? Is that something that you can speak to?
Yeah, so Shonna, you know that I always have an answer.
I know.
But no, but I mean it well, so I'm very thankful that NIH is really, supporting the Pheo Para extremely well. And even I left, so, and everything is even, with certain difficulties, and I cannot come about, I cannot comment about those difficulties because I'm not at the present time at the NIH, but I know that the protocol is actually open. The protocol is accepting patients. Of course, at the beginning was a little bit, I would say, limited, because the number of personnel. But I have to say that there is very good support, to keep the protocol running, to keep the protocol open and accepting patients. And thanks to especially the institute, which is called NICHD, National Institute of Child Health and Human Development, and also, or mainly, its directors, whether it's, clinical scientific director or director of the NICHD. So far, so good. And I know that the patients are admitted to the protocol. Just recently, for example, somebody was admitted as a pediatric patient. Of course, I cannot have any details because I am not anymore at the NIH, but I have at least, some information about, how everything is going. And the reason is that we are still, or I am still participating in some clinical and scientific studies based on, of course, the regulations and rules that apply to me as a person who is practically outside the NIH, so the external, but everything goes well. So I am very hopeful that things will go well and the program will continue and will be even better. Then compared to time when I was there, and my successor is absolutely wonderful and very good and very dedicated.
Great. So for patients who have information that lets them understand and know with their doctor that they do have one of these tumors, then they should contact the NIH and see if they're
absolutely.
eligible.
Yes. Yeah, they can contact NIH, and so of course, they will be directed to my previous group, including, for example, research nurse, nurse practitioner, as well as my successor, and they will be evaluated. Yes, absolutely.
Okay, excellent. So I want to switch gears a little bit. We've had a couple of questions come in about pediatric cases of Pheo Para. So, in general, do we know more now than what we used to about those, pediatric cases? And are we seeing any patterns there among, kind of the children who develop some of these tumors? Let's start there, and then I have a couple other follow-ups.
Yeah, this is, very broad question. So of course, we have a very good information about the pediatric patient, about, the genetic background. We know that is much more common, compared, for example, to adult patients. We have also, the guidelines that are related to pediatric patients. Thanks to, I would say, international group of experts. Those guidelines were published, I think, in 2024, and most important, I would say, expert behind that was Dr. Pamporaki and Dr. Casey. And this is very good, actually, guideline. I think it was published in Nature Reviews Endocrinology. And I would definitely recommend to look actually at those guidelines because they are very comprehensive and based on the really evidence, although the evidence is still, limited. And the reason why it's limited, not because, we would not have a tools, how to, for example, perform biochemistry, biochemical measurements or imaging, but because we don't have, enough pediatric patients, to put all the data together. Although I am very optimistic with artificial intelligence when, we will start collect the data, of course, under certain, again, rules and guidelines, so which would be very, very important. But I always tell my colleagues, collect, because once we collect more and more about every case, so we will have, better view what is going on. And I'm talking about the collection, global collection, okay? I'm not talking only the collection that will happen in the United States or Europe or, for example, Asia. Therefore, I'm calling for global initiatives, and I'm pretty sure that those global initiatives will happen. One of the very good example is A5, which is very good, because, so across the continent, and we will have maybe some new ones as well, because once we have a data, we can actually understand better, especially something which is rare, which is not easy actually to study or put together, certain, I would say, future steps, how actually to address not only those patients, but mainly how to treat those patients, So, but once we have those data, we will come up to something which I call synthetic trials, I don't want to go into synthetic trials and explain what I mean, but the AI will be definitely something that will help us. It would be our assistant. I'm not saying that it should replace, our thinking, definitely not, but assist us with, decision-making process.
If a child
Mhm.
has tumors, is it possible that that child could be showing symptoms, but it just isn't showing up on a scan
Well, that's interesting. The answer is yes or no. So it depends what kind of scan, So because no scan is actually perfect and optimal. Nothing in medicine is optimal. Sometimes I hear the word optimal. Nothing is optimal. Everything is suboptimal, So, but even some scans can miss, some tumors, and especially those tumors that they are very small. It depends whether contrast was used or not, and where the tumor is located. Because the tumor can be located behind heart, can be located in some area that is difficult to evaluate unless you use the combination or battery of scans. But I will tell you something. If the patients, for example, pediatric patient, has some symptoms and signs that are presumably related to catecholamine excess, so we have the biochemical test, which is based on the measurement of plasma or urine metanephrines. And if those symptoms and signs are related to elevated catecholamines, even they are actually, only lasting, for example, for a few minutes or, 10 minutes, 15 minutes. Metanephrines would be definitely elevated. Okay. So first you have to do the biochemical evaluation, because the biochemical evaluation these days can detect if you measure metanephrines, especially in plasma, okay, because the sensitivity for plasma metanephrine is slightly higher. It's 97% compared to urine. It's approximately 94%. So if you do it, you can detect the tumor approximately 6 millimeter in diameter. And that 6 millimeter in diameter can be sometimes missed by the imaging studies, okay? And especially, if we don't think about it, so much, or if the tumor is located in the area that is very difficult actually to see it, or in the area where, for example, I don't know anything about this patient, where the patient was, for example, operated, and then can be a recurrent tumor in that area. So it's very difficult actually to find, very small recurrent tumor that would be about 6-7 millimeter in size.
So if and here we're talking about a child,
Sure.
but it might be for an adult as well. So if they
Sure. This
had
is
a meta,
the same. Then the same apply for adult patients. The same.
so if they have a metanephrine draw and we see elevated, and they're having symptoms, and maybe they've had one scan, but that scan may not have shown anything, then what I think I'm hearing you say is we might need an additional type of scan.
Oh yeah,
Is that
you
correct?
definitely use the CT and MR, so in combination. So first, which is important, because anatomic imaging studies are very good and some of are very accurate, especially, CT scan, it's very, very, very good. And it depends sometimes on the mutation, the genetic background. If you know that, it's related to cluster 1, which is related to Krebs cycle. There is exception, for example, for fumarate hydratase, but usually that belongs also to Krebs cycle. So usually use the dotatate scan, and the dotatate scan is very good, to find out, if there is any lesion in the body, and it's also whole body scan. Okay. So it's
Yes.
very important. Of course, for the lesion 0.3 6 centimeter will be a little bit more complicated, but usually those new PET scan will be, close to also detect those lesions. And using appropriate radiopharmaceutical. If you have actually some other genetic background, like the patient may have a multiple endocrine neoplasia, in the history of neurofibromatosis, even VHL. So these patients, may profit from different function imaging modality, and that would be fluorodopa. The problem with fluorodopa is not really available in many institutions. For example, NIH has fluorodopa. I think there are few more institutions in the United States compared to Europe, where fluorodopa is available practically, I cannot say in all countries, but in many, many countries.
Okay, very good. So I have another question that is about a head and neck, well, multiple head and neck paragangliomas and an FH mutation. And this person was wanting to know, do we have any updates or anything on the FH mutation in connection to those things?
What is the question?
So the question, let me just read it to you. Has there been any recent updates on the FH mutation in connection to paragangliomas to help inform the best treatment, and what percentage of cases turn cancerous? Now, I know cancerous, can be.
Yeah, so there are good papers about FH and the paragangliomas, usually not related to head and neck paraganglioma, but related to abdominal paragangliomas, and about especially paragangliomas rather than pheochromocytomas, meaning that these tumors are actually not sitting in the adrenal gland, but they are outside the adrenal gland. Those tumors are a little bit more problematic, and the reason is that these tumors have, I would say, the metastatic potential a little bit higher than, for example, if you compare to VHL, MEN, or neurofibromatosis. So we have to be aware of that. And some data, they suggest about 5 to 10%, even higher, for fumarate hydratase. And for patients with this type of mutation, for example, fluorodopa is very good. It's like, certain exception from other actually mutations that are sitting in the Krebs cycle. So FH, would profit from actually fluorodopa. Okay? So when somebody has a FH, they have to be aware also of kidney cancer. So because the kidney cancer can come up with FH, uterine fibroids also, it's known, and as well as paraganglioma, and those paragangliomas are a little bit more aggressive than other ones. They are less aggressive, like, for example, SDHB, but definitely they are aggressive. Okay?
So that also would then, again, for our patient community, it's important to get that genetic testing. That's a very important thing.
Oh, absolutely. Absolutely. Yes, yes. And today we are using either, specific Pheo/paraganglioma panels, for genetic testing. And sometimes we can choose, which gene based on the biochemical phenotype. I don't want to go into that, because these days, if we use panels, sometimes it's a little bit cheaper, or the price is the same when we would, for example, suggest one or two genes. So it really depends on the company and depends on the, arrangement, for example, between, that specific company and, for example, medical institution.
Yes. And insurance. Some,
Yeah, and of course, insurance, what will be less expensive, but be guided, with biochemical phenotype, needs a little bit more, I would say, knowledge about these tumors. So it's much easier for practicing, for example, endocrinologists or practicing oncologists just to order the panel and to see, what is positive and what is not.
Yes, yes. Okay, great. So next we have a couple of other questions that have come in, and you addressed it a little bit earlier about anemia. And is there something about just in general paraganglioma, pheochromocytoma that causes anemia to come up, or is it more specific to, certain types like head and neck or, other types of tumor based on placement? What should patients know about anemia? Is it something they should be monitoring, thoroughly with their doctor? What do we know about that?
Yeah, so anemia, equals, the hypoxia, so because you don't have enough red blood cells, and that is very important, for the oxygen and carrying oxygen. So everybody who has anemia will be in certain hypoxic state. Patients, with anemia, let's say, generally speaking, you have a cancer patient. Cancer patient is, treated with chemotherapy, bone marrow will be actually affected, and sometimes, to very problematic uh, degree, because the suppression of the bone marrow will be, it can be very problematic, especially after several cycles. And what is happening with those people? They are short of breath. And if they are short of breath, and before they got, for example, blood product, or other product, for example, EPO, to increase the number of red blood cells, they will be short of breath. Why they are short of breath? Because they don't have oxygen. If they don't have oxygen, of course, they are hypoxic. So going back, to Pheo Para Alliance, yes, that will be problematic for patients who actually may have a Pheo Para Alliance related to mutation that actually is sensitive to hypoxia, okay? And those will be the mutations that are actually sitting in the Krebs cycle. And we talk about those, and especially would be, the most common will be those, related to succinate dehydrogenase, but also with the hypoxia signaling pathway, like, VHL, or, HIF2 alpha, or EPAS1. Those will be mainly affected. This is why, I am telling patients who have those mutations not to spend any time, in high altitude. If they have to go to high altitude only for a very short time, or, doing the sports where they will be short of breath. If they will be short of breath, for 5 minutes, 10 minutes, possibly okay. But if they will be short of breath running marathon, for example, for 2 hours, 3 hours, 4 hours, it depends, how fast they are, or, swimming, and or very strenuous exercise, or, cycling, for, 40, 50 kilometers and being short of breath is definitely not good. Okay. Because that would be actually affecting, hypoxia inducible factor, and hypoxia inducible factor will be, upregulated, and everything starts again, so the genes, related to development of tumors here, particularly Pheo Para Alliance, will be definitely overexpressed and can actually worsen, the disease. Not maybe for the first time, but if it is on a repeated basis, is definitely not good. So most patients, at least those that I saw, with certain type of mutations, I told them that would be better, if they switch to, I would say, decision, with their family, to instead of to spend vacation on yearly basis in mountains, to go to states for example, to enjoy sea level, and which would be much better, for those patients.
So everyone gets a beach trip, is what you're saying.
Yes, and they should, enjoy beach, very, very much, because there are also some other good things, the ionized oxygen, is generated on the beach, especially because of the waves, so if they are walking around, on the beach, I think it's extremely, extremely healthy.
Okay, very
Or
good.
if they spend, in the forest, if they spend a lot of time in the forest, but again, not in high altitude. That's
Okay,
my
very good.
view. That's my recommendation, so, but I think that it may work very well.
Okay, excellent. I think you've just made some people very happy because they're going to do a beach vacation now.
Yeah, but maybe some of them may not be happy, because one of their family member likes mountains, and climbing, and so I understand, but sometimes, in our life, we have to sometimes adjust, certain parts, and to deal with whatever is necessary, and what is good for the health of the person who actually may have certain type of the mutation.
Correct. Yeah. And it's important for us to always acknowledge our caregivers and those,
Sure.
who are in our family who help us, those of us who have those tumors, it's a family and a caregiver. We're all in
Yeah.
this, in our positions, we're all in it together. So
Yeah,
yeah,
but I can
that's
tell you, a good family always make, the reasonable and the best decision, in the favor of the person who needs, some help, support, and having good and understandable, family members around.
yes, absolutely. All right, we have a couple of more questions I think we can get in here. So one question that came in, and I think we've addressed this, but I think this one's always good for us to talk about. Um, the long-term effects of having, this elevated catecholamines kind of going, especially on our heart and our lungs and, some of our organs. Can you talk about that a little bit?
Yeah, it's definitely problematic, because, catecholamines, if they are elevated on the, long basis and for a long period of time, are definitely problematic, dangerous, especially for cardiovascular system, because, those patients are presenting with arrhythmia. Usually it's tachyarrhythmia. Sometimes they can go to even more problematic arrhythmia, like, for example, atrial fibrillation, even ventricular tachycardia, which is, very, 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 very problematic for those patients. And of course, they present with the hypertension, whether this hypertension is like paroxysmal hypertension in many patients or steady, the hypertension. So, and of course, it's not good because, if somebody has, for example, hypertension and arrhythmia, so it's affecting the function of many organs, and those organs suffer quite a lot. So on the long basis, everyone actually will present with complicated scenarios and dysfunction of many organs. Therefore, those patients must be treated with blockade. We call it adrenergic blockade or adrenoceptor blockade, and we usually use the alpha blockers. And if they are presenting with tachyarrhythmias, we are using beta blockers. There is some drug that is called Demsr, decreasing synthesis of catecholamines, which is excellent drug. Unfortunately, it's very expensive, but it's very good for patients with metastatic disease in whom, the levels of catecholamines are tremendously high. Those patients are really suffering from, having very, very severe hypertension. sometimes between 150, 160 to 200, 220, even higher. And then, after, the that episode, sometimes the blood pressure goes to, let's say, 90, 100. So for 1 hour, 2 hours, they are, very hypertensive. And then, as a consequence, because the tumors stop working, that way, or almost are depleted for a certain period of time, everything goes down and they have a hypotension. And it's very, very difficult, to treat those patients. Therefore, the Demser is very, very good drug for these patients. But unfortunately, the insurance is sometimes reluctant, to pay for Demser because it costs a lot of money. Some states are better, some states are more complicated. And some patients, of course, cannot afford, this medication. But I think it's very, very good, very good one, because once you decrease synthesis of catecholamines, patients will do much better in terms of hypertension as well as, hypertension as a consequence of attack that the patients are presenting, with, if they have especially metastatic disease.
Say the name of the drug again for our patient community. What is the drug?
Demser. This is Demser.
Demser.
Demser, alpha-methylparatyrosine. Demser, D as a David, EMSER, Demser. So, and it's really very, very good drug, and I very much recommend it. And we used to use it at the NIH practically on weekly basis, especially for patients with metastatic disease. And it was the results, the outcomes were actually very good.
Okay, good. So that's good for our patient community to know the name of that, and they can talk to their doctor about it. Especially, it sounds like if their blood pressures are up and down and up and down,
Exactly,
and hard
exactly.
to stabilize.
Yes,
Okay.
and especially when they present with very high catecholamine levels, because we cannot actually, even we use the adrenergic blockade, we cannot counteract such high levels, the action of such high levels of catecholamines. It's very difficult.
Okay. Okay, very good. All right, one more question here. If a person has head and neck paragangliomas and they have not grown for several years, what's the likelihood that they would start growing?
So likelihood is very, very good, because you have to understand that approximately 40 to 45% of head and neck paragangliomas will not grow. And there are some very interesting papers, and I actually believe those papers. So if you, for example, as a doctor or even a patient, will find out that has head and neck paraganglioma in certain location, so they should not rush into surgery. They should actually wait, and they should watch, what is going on with that paraganglioma in the head and neck area, because as I said, approximately 40 to 45% will not grow. So because that size, let's say, will be 2 centimeter, 2.5 centimeter, will stay there, for a long period of time, or even will be the final size. So of course, some of them, they may say yes, it will not grow, so, but maybe in a 5, 10, 15 years, it may grow. What should I do? So it's really personal preference. Some, they don't mind, to have for example, MRI. MRI will be most likely the best, the imaging study, as an anatomic imaging study for these tumors. And they don't mind to go every year, through the imaging. Because this is how it is. Some of them will tell you, even if I have a 2 centimeter, the tumor, I'm afraid that it will grow. So I would prefer the operation. And if it is in the area that these tumors can be operated, definitely, the operation can be actually considered based on, the health conditions of the patient. Here, I would like to say or mention one information or share one information. Very often patient with vagal paraganglioma coming can say, I was advised by doctor that, this vagal paraganglioma, that is 2 centimeter, can be well operated, and the consequences maybe not so problematic, or maybe there won't be consequences. I would say that I would say consensus from most experts, is today do not operate on vagal paraganglioma unless there is a problematic situation. For example, it's paraganglioma suddenly growing, very quickly. This vagal paraganglioma causing, very, very severe pain. There is, suddenly, some bleeding, or something else that, needs to be addressed, because, vagal nerve is going through vagal paraganglioma, and when it's removed, even it's 2 centimeter, even smaller, they will have always cranial nerve deficit. These paragangliomas can be very well addressed by radiotherapy. There are very good radiotherapy approaches. Patients are doing very well. They are very stable, and it's very good. Of course, nothing is 100%. I had maybe 1 or 2 patients who came to me, and they presented with practically no residual deficit. However, at the beginning, they had residual deficit. They went through very extensive rehabilitation, sometimes 6 months, sometimes 12 months. It's extremely costly compared to, very well established radiation. So if somebody is presenting with vagal paraganglioma, they should get not only second opinion, they should get third opinion, and they should always ask the doctor, if you feel that I will not have a deficit, show me the statistics, show me how many you operated, show me exactly the chart, how many had, for example, residual defect or not, and let me to talk with at least 2, 3 patients who were operated by you. I would like to ask them, what happened and what especially happened after the operation.
Yes, always important to get second, third opinions and find out who your surgeon
Here I
is.
would get even surgery, and I know very excellent surgeons in the head and neck area, very excellent, including, Vanderbilt group and other, the surgeons, they are very, very good, so nothing negative, but, we have to be honest to our patients, and especially knowing that, radiation approaches today are extremely good with minimal side effects. I would always consider those compared to, for example, tympanic paragangliomas that can be operated, and they are operated by very experienced surgeon. So they have those patients, they have a very, very good outcomes.
That's fantastic. I think we will have a good group in our patient community that's glad that they heard you say that. So that's really good. We're a few minutes over our time, but I know you like to answer questions, so I'm going to put a couple more out there for us.
Yeah, you can definitely, ask a couple of more questions. That will be absolutely okay with me.
Okay, just a few more, and I think these might be simple, but I don't know. Is hyperbaric oxygen treatment safe?
Oh, hyperbaric oxygen, there are not really, very good data or, studies that I'm aware of. Although, there are studies about cancer patients with hyperbaric chambers, and those patients actually improve, and they had, good response. I would say yes, possibly, although, the type of oxygen well, it's maybe not the type, and everything around, that I would actually perhaps, recommend the most. And so for me, it's really very difficult to comment because no experience. I think I had one patient who from Ireland, if I remember well, and I think that the patient went through, this type of therapy and did pretty well. Okay. But if you would ask me if I would recommend or not, no comment because, I don't have experience. I did not see very good solid paper. So it's difficult to make some very good and useful recommendation.
And especially, we have other treatments. So,
Definitely we have other treatments as well. Yes.
okay, very good. There was one other, let me think about which one it was here. I saw it on my list. Every year we talk about the protocol for testing. I think this may be a great question for us to end on because it is always one that the patient community talks about. So, and you said it earlier that the plasma test is a little bit better than the urine test, but patients always ask about, the protocol as far as should the vial be chilled and, how long, should there be preservative if it is a urine. Is there a place that we can send patients so that they get that exact information? I know that Pheo Para Alliance has some of that information on our website, and I'm going to encourage patients to go there. But is there anything else that you'd like to make sure our patients know about proper testing?
Yeah, so I think that I would recommend patients to go to, the Pheo Para Alliance website. It's extremely well done, especially Dr. Lenders, myself, and others as well participated in that information to be very correct. And especially, related how biochemical tests should be run, what should be done and how patients should be prepared. I think that the easiest way, because otherwise we would spend, 5-10 minutes, is the easiest way to go, to a Pheo Para Alliance website and to see, what needs to be done. But there are definitely some precautions and they should be met. Remember, patients must, be in the bed, laying flat, not with the pillow, flat, for at least 20 minutes. Sometimes, 30 minutes will be even better, but 20 minutes is the minimum. And I can guarantee you that the results will be very, very, very accurate if everything is done, in certain way, including, being in the bed without a pillow.
Okay, thank you so much, Dr. Pacak. And we are about 10 minutes over our 1 hour, but that's okay. I think
That's no
patients.
problem. Even if it would be 30 minutes, will be fine, but I know, so we have some limited time, but that's okay. I know that there are some, in the chat, some questions, here, but I'm not able to answer those questions, right now because we have limited time, but I wanted to tell patients they can always actually reach me. And please, you can provide patient with my email address. There is nothing, to be hidden. My email address is pretty well known, and they can actually they can reach me, and I will be happy, to answer their questions because right now, there are many questions in the chat, but I'm not able to answer them about, infrared, about, flying, or something else because it would need at least about 10, 15, 20 minutes.
Sure. And there, some of the questions I would recommend to our patient audience to go back and watch some of our previous fireside chats. We have answered some of those, and they are out on our YouTube channel, so they can find those. But of course, Dr. Pacak's always very generous with his time, and he will get back to you. It may take him a couple days, but he's even pretty good about that. It's normally pretty quick. So
Maybe not,
we
maybe
always
not couple days, but maybe next time we can do, fire chat for 2 or 3 hours. I don't know. I will be definitely ready. I am not sure if, the other ones will be ready, so,
maybe
but
we'll
because,
call it the
you know,
marathon. Maybe it's our marathon fireside chat, and we'll do
maybe
a
we should call,
really
we
good.
should maybe a little bit modify, the title of this, at the end of the year, I would say webinar. So I think that would be good. But as I said, I will be happy, to be in touch with patients. Please, contact me on my personal address, email address, and I promise you, I will be in touch with you.
Yes, and we know that you will. We thank you so much for always thinking about us as patients and for all that you do for our community. And we hope you have a great holiday.
Thank you so much. Once again, thank you for the invitation, from Pheo Para Alliance. Thank you, Shonna, being, with me and moderating, the entire webinar. I also would like to thank patients, for their questions, for their interest. And as Shonna mentioned, I'm still around. I will be around. I am not retiring. Some people, they think that I retired. I am not. I did not retire, and I'm not retiring and working still, especially on the pheochromocytoma, paraganglioma. So as I said, if you will need, some help or support or something like that, so of course, you can contact me. Otherwise, I would like to not only thank all of you, but wish you very nice, very happy holiday season, and especially to our patients, very good health, and good things around. And if somebody is treated, good responses and all good outcomes. So thank you so much.
Okay, bye everyone. We'll see you next year.
Thank you. Thank you. Take care.